they have identified at the last count, means this was 7th edition, last count, we have identified 290 names of modes on 33 ventilators in United States alone. So imagine how many modes are there and how many different kind of ventilators are there. It is just difficult to accept that these modes are different and each mode has different to offer. So if one looks into detail of these modes, more or less they are same. If different, then difference may be minimal, and how much clinical relevance it has as far as outcome is concerned, that no one knows. So this slide particularly is from Dr. Saurabh Datta slide, my very good friend. And this is a soup of various modes available on the ventilators. You can see various things are available that makes you feel dizzy that what I'm going to face when I'm going to see these babies, see these modes. Now, before I start, there is going to be some repetition of what my friend Dr. Sanjay Wazir has discussed. He discussed about the basic mode, but without few important concepts, we can't go ahead, and that's why I'm going to repeat a little bit. When a baby is breathing spontaneously, you can see here that there is always a positive flow going into the lung. Intrapulmonary pressure goes to the minus side and a positive pressure breath is created. And then when you can see baby exhaling, you can see the flow is coming out, so negative flow, and the positive pressure in the intrapulmonary pressure is built up. This is a spontaneous breathing. When it comes to, sorry, it is not moving. Okay. Yeah, sorry. So when it comes to delivering a positive pressure breath, you can see here that both are becoming positive. That's flow and the pressure. And that is why a mechanical breath is also known as a positive pressure breaths. When you talk about creating artificial breath, you have three things to keep in mind. One is trigger. So what causes the breath to begin, or what will trigger the breath? Trigger in the sense that a ventilator will receive some signal from the baby and a positive pressure breath is delivered. So which is that signal because of which a ventilator is delivering a positive pressure breath? Is that the pressure or is that flow which is making a ventilator to deliver a pressure breath? When it comes to limit, you talk about either it's a pressure limit or volume limit. What does it mean that when you talk about pressure limit means set pressure is delivered and inspiration ends. So the pressure reaches preset value before inspiration ends. And volume limit is certain volume is reached and inspiration ends. So that is about limiting a positive pressure breath, and that is what you are seeing here, that a limit is either pressure or limit is either volume. And then you talk about cycling to the next breath. One breath is created. What makes them to go to the next breath? Is the time because of which the next breath is started? Is that the flow? Because the certain flow is delivered, now next breath will begin or inspiration ends. So it is a termination or cycling of the breath, which may be pressure or it can be, time, or it can be flow. We know that this is what IM happens, in the IM intermittent ventilation happens. Ventilator and baby both are breathing at the different rate, different pressures, different I time. So the ventilator breath is being pushed into the baby's lung, irrespective of the patient is breathing or exhaling or inhaling. Two words are important: control breaths and assisted breaths. Control means that ventilation is provided by ventilator initiated mechanical breath. Assisted means Ventilation is provided by patient-initiated breaths. So we discussed, Dr. Sanjay Waziri discussed day before yesterday about SIMB mode. You can see here, this is a mode where patient is allowed to breathe spontaneously. If baby is breathing, let them breathe at their own rate. Here you can see that this is a negative deflection. So that is all spontaneous breaths, negative deflection. But intermittently, on this negative deflection, a positive pressure breath is delivered, and that is your SIMB breath, synchronized intermittent mandatory breaths. Rest of the breaths you can see here are the spontaneous breaths, and ventilated baby is allowed to breathe on their own. Here you don't see any positive deflection, means no support is being provided by the ventilator. Only for the selected breaths, ventilator will provide the support. So that is, selected number of breaths are supported. Rest all parameters, PIP, PEEP, I time, flow, and FiO2, all is set by the physician. Baby will be allowed to breathe spontaneously intermittently between two triggered mechanical breaths. Here you will set different tidal volume for the spontaneous breaths and different tidal volume for the mechanical breath. What happens in assist control? You can see here all these are negative deflection, which are spontaneous breaths, and with each negative deflection you can see a positive pressure breath, which is mechanical breaths. So if baby is able to trigger the ventilator, ventilator will support all triggered breaths or mechanical breaths, and you can see good tidal volume happening because all breaths are supported breaths. So here all spontaneous breaths are synchronized or assisted breaths. Rest all parameter is decided by the physician except the rate. Rate is decided by the patient, and that is goes with the assist control. Problem with assist control that you need to make sure that you don't keep your backup rate very high. Why so? Let's see that I keep the backup rate 60, means one breath is 1 second. Your I time is 0.4, so your E time will be 0.6. Patient has got fever, patient goes pain, patient is, patient is hungry or agitated, because of which the rate goes to 90. That means now one breath is just 0.6 second. And with 0.6, your I time is 0.3, so it's not enough time for the exhalation, which will cause lot of problem, auto PEEP, or because of that auto PEEP, some lung damage. Typically, you can see this is pressure volume loop and the flow volume loop. You can see here that with mechanical breaths, each breath you can count here, each breath is different, each breath gives different pressure, each breath gives different volume. That is typical of IMB. SIMB, you can see the small spontaneous breaths happening here. And then these are big mechanical breaths happening on the other side. So you got small spontaneous breath, which is small tidal volume, and the mechanical breath, which is a bigger tidal volume. And then you got assist control mode, where each breath is going similar again and again. So good amount of tidal volume is being generated with assist control mode. In all, assist control may end up with delivering more tidal volume, more lung damage, and more CO2 washout in comparison to SIMB mode. This is what is happening with the assist control. You can see here that continuously most of the breaths are the triggered breaths. All breaths are supported. Good amount of tidal volume is delivered. Here with 18 PEEP, 8 min is there, and you can see the tidal volume delivers 6.97. So that is typical of assist control. But the problem with assist control or SIMB is that beginning of inspiration is synchronized. You can see here that this is like a spontaneous breaths. A negative pressure breath is delivered, a positive deflection happening, and this is your mechanical breath. You can see here that the patient is getting into exhalation, machine is still into inspiratory phase. So I want to breathe out, machine is still into inspirative phase. So machine is still pushing gas into my lung or the flow of the gas into my lung, and I want to exhale. And that is where the asynchronous will take place. So with SIM or access control, initiation of inspiration is synchronized, but termination of inspiration is not synchronized. Same thing showed here. This is meditative breath. This is spontaneous breath. Here the spontaneous breath is coming to an end. Still the ventilator is in exhalation space. Second inspiration has begun, but machine is still in the exhalation phase. So a lot of asynchrony either with assist control SMB. And this is simply because patient's eye time is always shorter than ventilator eye time. Each breath of a baby is different, day to day wise, weight to weight wise, disability, disease wise. And I can't catch eye time of my baby at each minute or each second or each day. Machine can't catch that. Machine has got fixed eye time. So baby's eye time differs, machine eye time is constant, and that cause enough of the exhalation asynchrony. There is one problem with SIMV and assist control. Second problem is you can see here that a positive pressure breath is happening. You can see here the flow is getting, the moment the mechanical breath is started, the flow is getting into the lung, the pressure is building up. The moment the desired pressure is reached, that is your PIP or pressure limit is reached, further flow is not given to the baby, flow is a decelerating. But the pressure is held for the eye time that you have adjusted on the ventilator, which may be 0.3 or 0.4 second. So the pressure is reached, but further flow is not there. And that is typically known as inspiratory hold. I am breathing and then I'm holding the breath. So there is sort of flow starvation that will happen. And that is where the problem is. Other way, the moment this pressure is reached of 20, let's see that this is a mechanical breath. Pressure is, flow is getting into the baby. 8, 12, 16 flow is getting in. Reach to the 20, now further flow is not there. This flow is held for next 0.4 or 0.5 second. So during this period, there is no flow because proximal end of the airway and the distal proximal end, that is lung, and the proximal end is mouth, and the distal is your alveoli. Both are now equilibrated with the same pressure. So more flow will not get in, and that is known as the inspiratory hold, and that is not a good feeling. In short, with S7 assist control, the trigger part is good, inspiratory beginning is fine, but cycling is not synchronized. Exhalation is not synchronized. To improve that cycling, the mode that is being used is pressure support ventilation or PSV, which is a flow cycling and not the time cycling. It goes by the, and this is a mode where termination sensitivity will come in the picture. So what is termination sensitivity? Imagine that you are blowing a balloon. Once you blow to a certain pressure, further flow is not required. So the deceleration in the flow, which can be 5%, 15%, or 20%, depending on the adjustment that you want a ventilator, that 15, 5 or 20% of the deceleration of the peak flow, 5%, 10%, 15% peak flow, that deceleration occurs, that's the time exhalation opens up and ventilator breath gets into exhalation phase. And that is typically known as a termination sensitivity. You can see here that pressurization has taken place. Now the flow is peak, the pressure is reached, pressure has been held, but now flow is getting lower side because now further flow is not required to keep this lung open because 20 to 20, that's it. Pressure is already reached. Further more flow is not required. And you can see here, the moment it goes to 15%, you can see a 15% of the peak flow, the exhalation begins, and that is how the better synchrony in the exhalation is achieved. So there is no inspiratory hold. You can see, and now we compare the previous figure, you can see here this is what was happening here, that inspiration was ending, flow was getting not there, so there is no flow, and now this was exhalation, so this was inspiratory hold. Now when you put them on pressure support, you can see here there is no inspiratory hold, and inspiration and exhalation, exhalation is inspiration also triggering of the inspiration is synchronized, as well as beginning of exhalation or end of inspiration is also synchronized. This is typical SIM your assist control. There is a time cycle breath. You can see here there is inspiratory hold. You put this baby on the pressure support ventilator. Now this is flow cycle breath. And because of the flow cycling, the inspiration and exhalation is synchronized and there is no inspiratory hold. That is beauty of pressure support ventilation. This is typical ventilator screen. You can see here that inspiratory hold is not there. So what is PSV? PSV is like assist control where all ventilator breaths are triggered by the patient. Once the breath is triggered, pre-decided pressure is reached at proximal airway. It reaches here. And near end of spontaneous inspiration, drop in the flow is registered and inspiratory flow is terminated. We already explained that. This is typical of PSV. Now you can combine PSV with SIMV. We have seen in SIMV, when baby is breathing spontaneously, baby has to breathe through anatomical and instrumental dead spaces. Because the long tubing is there, endotracheal tube is there, there is a flow sensor, there is a T-piece. So when I want to breathe spontaneously, I need to get out of the resistance of all this extra thing which are there in the airway. And for a small baby like 8,000 gram, this may become too much for the baby. How can I avoid that kind of? Ultimately, it will baby get tired, baby gets fatigued, there's increased work of breathing, particularly for the small small babies, and that for spontaneous breaths. Mechanic breath is not a problem. SIMV mechanic breaths are not a problem. But when you are weaning them on SIMV mode, you try to put them on 30 and 20 rate. At that time, all spontaneous breaths are for the all spontaneous breath, baby has to breathe through this anatomical and instrumental dead space. How can I get out of that? You can see here that these are, you can see here that these are spontaneous breaths where mechanical breath is not given. So these are spontaneous breaths. By keeping them on SIMV plus PSV, there is some pressure support is delivered during the spontaneous breaths. So for example, babies ventilator 30 SIMV rate, every 2 seconds a mechanical breath is delivered, which will be triggered once, and with that the baby will have proper PIP and all that. For rest of the breaths, you can see here, just a minute, because there is some fluctuation in the, yeah. Now I can see here, is it clear? Now you can see here that during this part, there is some pressure being offered through which baby can breathe easily. There is no increased work of breathing. Baby will not get tired or fatigued. But ultimately, the PS breath will take over burden of that extra things. In short, I have some fluctuation here. There is, I'm sorry for this, but yeah. You can see here that typical SMV where inspire is triggered, the assistant to each breath not there, ventilator rate is fixed, inspire time is fixed, and PAV. There is no help for the baby except the triggering in SMV mode. When it comes to assist control, apart from the triggering, there is assistant to each breath is available, which is good for the small baby. But the rest of the things are not available. It is decided by the physician. When it comes to PSV, yes, you have a trigger there. all breaths are supported, variable ventilator rate, inspiration time is decided by the patient, only pressure is not with the baby. So that is the beauty of PSV, because it can bring a mechanical breath as near to physiological breath as possible. Now differs long back realize that if one pushes a big tidal volume into a rabbit or critter with a strapped chest, it doesn't hurt its lung. Even when PIP or the pressure being pushed is very high. So chest was strapped and pressure was pushed in the rabbit's lung, it didn't hurt the lung. But at the same time, if the same pressure or even lesser pressure was pushed into critter's chest without strapping, that caused good amount of the lung damage. And later on, his colleague realized that they did postmortem of the animals where high tidal volume and high pressure was delivered, and they show that it increased the lymph flow and protein leak by 7 times. Against, if high pressure but normal tidal was pushed, it decreased the 30% lymph flow and better protein clearance. So that means it is not the pressure, it was the volume which was causing trauma. And if you can see this bar diagram, 3 kind of rodents were ventilated with 3 modes: high pressure and high volume, low pressure and high volume, and high pressure and low volume. And you can see here where the low pressure was low, but the volume was high, middle bar in the each one. Maximum damage was seen in form of protein leak and in form of lymph flow or lymph flow. Leak of the protein and lymph flow was increased when baby had low pressure but high volume. The animal was ventilated with the low pressure but the high volume. The damage was minimal when even with the high pressure, the volume was kept low. And that brings the fact that it is the volume trauma that is more dangerous than the barotrauma. If you look at pressure volume loop, here is the pressure PIP. And with this PIP, let's see that this is the volume which has been delivered. You give surfactant, the compliance improves. With the same pressure, now high volume will be delivered. That means patient is improved actually, but the volume being delivered will be more if you are not careful, and that will cause the problem. You are in the nursery, baby is becoming sick, compliance is decreasing. Now with the same pressure, the compliance, because the lung baby is sick, less volume delivered. So this all will cause a lot of problem with the volume delivery. As against that, if you use volume ventilation or volume limited ventilation, you can see here that you are adjusting volume now. And with this volume, let's say that we are delivering this much of the PIP. You are given surfactant with which compliance will improve, because of which ultimately you will be able to deliver same tidal volume with less pressure. So you are targeting the volume, but you also can get the control of the PIP. If baby is becoming sick, compliance getting worse, with the same tidal volume, now more PIP will be delivered. Will be required to deliver that much tidal volume, more PIP will be delivered. So this is a fact that volume ventilation can, with volume ventilation, one can better control over the volume, which will prevent volume trauma, as well as because the volume will control the pressure, barotrauma also can be looked into. Let's talk about the scalar diagram of pressure versus time. This is your pressure limited ventilation, where your square wave, the wave on the pressure time curve scalar will be square wave, versus volume limited ventilation, where gradually with flow the pressure is building up. So typical presentation on the scalar diaphragm, on the pressure times scalar diaphragm, the pressure limited wave will be square, while you will see increase in the pressure at the end of the inspiration. That is typical volume limitation. If you look at the flow time diagram, you can see here that flow has increased, but then there is inspiratory hold. That is typical of pressure volume or pressure limited ventilation. As against volume limitation, volume limited ventilation, you can see the flow scalar diagram is square because the flow is delivered. Now gradually pressure is building up till the pressure is reached and then it gets into the exhalation. There is no inspiratory hold with this kind of ventilation. We have discussed already this, that this is your pressure limited ventilation, this is your volume ventilation. You can see the square wave here and flow is like this, and in the volume ventilation you can see the flow time loop time scalar graphic is square waves. So volume control limit ventilation is most of the unit in overall the world, particularly in NICUs. Just a minute. Yeah, volume control ventilation not preferred in most units. Preferred method is volume targeted ventilation. Pressure limited ventilation, that this is a volume target. What is volume target ventilation? This is a pressure limited ventilation that adjusts inspiratory pressure and or time to target a set tidal volume. So that means this is you are targeting the volume, but also you got control over the pressure. And that is why this particular kind of mode is known as a hybrid modes. Different kind of hybrid modes are available in the market or on the ventilators. These are volume guarantee, PRVC pressure regulated volume control, VEPS volume assisted pressure support, TTV targeted tidal volume, and volume limit ventilation. So these are the different things which are currently available on different ventilators. So what is good and bad about pros and cons of both ventilation? Volume control, as we discussed that as the compliance improve, the pressure also goes down. So auto weaning happens. And because of that, there is loss volume trauma and the pressure trauma. Problem is PIP is uncontrolled. So when the baby is disease or the compliance decreases, there is more pressure be used to deliver same tidal volume, and that increases the barotrauma. There is fixed flow rate. Patient demand may more than the set flow, and that time there is increased work of breathing and asynchrony. Patient demand will increase when patient deteriorates. So when patient deteriorates, the volume control mode can have some problems. Pressure control mode, it is a better expansion of the lung because you're doing a positive pressure breath, right? You are square wave there. So better alveolar recruitment will be seen with the pressure control mode. Better gas distribution will be seen. And initially there is, because we see that it was going up and then coming down. So initially this gradually flow is picking up. So that is less barotrauma actually. But the problem is volume trauma. With pressure control mode, how much volume has been delivered, particularly when the lungs are getting better, no one knows. It will as we have seen with improving the compliance, the pressure control mode will end up delivering more volume, and that is a problem with the volume trauma. Basically, for all ventilators available in the world, one need to see that all modes you can see are SIPPV, SIMB, PSV, and MAB. Both modes can be pressure control or can be volume control. But as we know that, we'll discuss little later, volume control modes, we are not using in newborn because certain reasons. We want both things because our baby's lungs are really very delicate. Baro and volume trauma we want to avoid. And that's why the best mode to ventilate our babies with volume guarantee, volume targeted ventilations, VEPS, that is volume assured pressure support, pressure regular volume control, volume support ventilations, so many things are there. One of them may be good for a baby and one need to understand it indoor. So what is about volume guarantee? This is a volume targeted, time cycle, pressure limited mode. You can see the pressure limited, time cycle TCPL was a conventional word that we are using. TCPL means time cycle pressure limit ventilation. That is what we are using. And that was typical of any access control, SIMV or PSV. Now, with volume, with benefit of volume, if you want to achieve, if you want to, we want to get benefits of the volume control modes, then you put volume guarantee onto that. So what happens that the operator decides a fixed tidal volume or targets a tidal volume and also selects the pressure limit. Here, the ventilator will measure exact tidal volume of the previous breath. And according to that, machine will decide how much pressure is required to deliver a next breath. For example, here you can see that I set a tidal volume of 6 ml. So I have targeted on 6. My pressure is, example is 20. So the first breath that has been delivered, it will measure the volume, which is coming to exact tidal. You can see the exact tidal volume, which is 8.1 with the pressure that I have delivered here. But just too much for my baby. So with next 3 or 4 subsequent breaths, exert volume has been calculated every time. And depending on that, the pressure of the subsequent breaths is decreased. So you can see here, it will keep on decreasing till the desired tidal volume is reached. And that is your volume guarantee. But when we use word volume guarantee, it is misnomer. Why so? Because it can increase the volume, increase the pressure to deliver the desired volume within Pmax that you adjusted. This cannot go beyond this. The volume required, volume is delivered within the Pmax that you adjusted here. Pmax will not automatically increase. It can decrease the pressure when the volume delivery is too high. Immediately the next breath, the pressure will be delivered, less pressure will be delivered. But in a case where the lungs are getting worse or something has gone wrong with the baby, you need more pressure to deliver the targeted tidal volume. Machine will not give that extra pressure beyond Pmax. It says check the settings or low tidal volume delivery. Some kind of this kind of message will be delivered. Problem here is that we have seen that it is not breath to breath. Several breaths are required to deliver the set tidal volume. Basically, it is designed to avoid overinflation. And when the tidal volume is very high, for example, my spontaneous breath is really very good. I've woken up and I'm breathing, I have good, strong spontaneous effort. At that time, if the tidal volume is too much, the breath is terminated, inspiration gets terminated. That is good about it. But as I told you, the term is guarantee is misleading. If leak is more than 40%, it is not going to work. And in a complex patient where the collapse, consolidation kind of situations, these are the one, or when the baby is in a chronic condition like BPDs, these are the one which may not be very helpful for the baby's disease process. Advantage, you already know that it decreases the volume trauma, it has stable turnover deliveries, or auto weaning, PIPs, less PIPs required if the good spontaneous efforts are there. These are advantages. But the limitation, as we say, that larger leak, volume guarantee or any volume mode will not be very effective or worth relying upon, or worth of any advantage. This is what we are doing. This is your assist control. You are putting the VG on. You can see here that VG has been switched on. And the moment VG switch on, this here the tariff was set at 25. Max patient is 22. The moment it's been switched on, you can see here that volume guarantee. With that, you can see auto change in the PIP. 13, 15. So depending on the baby's lung condition, compliance, it will keep on changing the PIP on its own. And that is beauty of adding volume guarantee to any SIMB, assist control or PSC modes. Now, this is about problem with, so with the PSP and VG, the problem is that it corrects the problem, corrects the tidal volume of the pressure in next 3 breaths, number 1. And number 2, that it cannot increase the pressure if required. So you have got a hybrid mode where the changes are done breath to breath. And you have got a hybrid mode where the changes are done within the breath. As long as changes are done in breath to breath pattern, there are 2 important modes: VG, volume guarantee, or pressure regulated volume control. What is that? This is a pressure limited time cycle mode that adjusts the inspiratory pressure to target the volume based on the tidal of previous breath. So that means you can adjust the pressure to achieve the tidal volume. What is that? You can see here the first breath is test breath, and that is your volume breath. With this, the machine will measure compliance, resistance, and all kind of things will measure. And based on that, it will deliver the subsequent breath to achieve the tidal volume that you are targeted. You can see here that compliance calculator of entire microprocessor calculates PIP required to deliver the tidal volume. That is what is happening here. You can see that it delivers 3 breaths at 75% of calculated breaths. It delivers 3 breaths at the 75% of calculated breath. And it increases PIP by 1 to 3 centimeter if with this 75% tidal volume is not reached. That is the beauty of PRVC, because as we know that with volume guarantee, you can't increase the pressure. Here, it can increase the pressure beyond the P max that you adjusted. That's beauty of it. It also can decrease PIP if your tidal is very high. So here you can increase and increase both way. It can go. Here you can see it can increase and it can decrease both way. Increases by 3 and decrease by 5. That is what the PRVC mode will do. You can see here, this is first test breath, and you can see here that desired tidal volume is at this level. Now, for this tidal volume, this much pressure is required, that is been registered. This is your P max. With next breath, again it will deliver at the 75% already discussed. With that, the desired tidal volume is not reached. It will increase the pressure to deliver the tidal volume. It will keep on increasing till the desired tidal volume is reached. Once it is reached, it will keep on adjusting the tidal volume depending on the adjust pressure depending on the tidal volume. So basically, this is a pressure limited hybrid mode where the tidal volume is targeted. Clinician sets the tidal volume and the maximum pressure. The first breath is volume control breaths, as we discussed, and the next 5 breaths will be the breath change in PIP is limited to 3 above and 5 centimeter below. Only thing about the PRVC and volume guarantee is they are constantly catching up. What does it mean? That the changes that are happening are not real-time changes. It doesn't happen within the breath. The changes are happening with the subsequent breaths. And at times, this breath is weak, but the next breath will be stronger, where this change in the PIP is not required. So that is the problem with the modes where the pressure and volume are adjusted in the subsequent breaths. If these are happening in the same breath, yes, it is worth using that. So which is the mode where the changes are hybrid mode, which is hybrid mode where the changes are happening within the breath. And that is typical volume assured pressure support mode. So what is happening here? You can see here that first breath is your pressure support breath. You can see here that you can the diaphragm is reached at the end. This is typical pressure support breaths. The pressure is square wave. The flow is also decelerating, and the volume is reached at the end of it. Now everything is measured. With the subsequent breath, ventilator is supposed to reach to this targeted target volume. If it is not happening here, if it is not happening, then it will boost up the pressures to make sure that desired target volume is reached. Let's see what happens here. Set the pressure limit. You set the target volume cycle threshold. Flow is been delivered. The desired volume and the pressures of compliance and resistance is being measured. Target volume is met, good. It is flow cycling, that's fine. Subsequent breath, you can see here the target volume is not reached. Pressure is there, but that is not reached because of some or other reason. There will be boost up in the pressure immediately. So the volume ventilation will change into pressure ventilation, and that is your volume assured pressure support. And that is happening within the breath, and that is the beauty of this thing. So what is VAPS? It combines volume and pressure ventilation within a single breath rather than using breath averaging algorithm. Each breath starts as a pressure limited breath or pressure supported breath. If target is reached, the breath is terminated as PSV. If not reached, the breath converts into flow cycle mode by prolonging I time with passive increase in PIP. And once the width is reached, it cycles in exhalation. And that is what you want. You want to control the pressure as well as the volume, so that even if patient improves, the things can change. If the patient is deteriorates, compliance get worse, again things will be changed depending on the baby's requirement. Each thing has its drawback. Problem with the VAPS is that it is not the exact volume, it is inherent volume which is being calculated. And we know that there is enough of the leak in the endotracheal tube in a newborn population. So actually, how much time is being given to the baby is always a question. Second thing is that there is no provision for automatically lowering PIP as compliance improves. And automatic weaning is not possible. That's drawback of this particular mode. Let's talk about another mode, which is mandatory minute ventilation. This is the mode where volume guarantee is there, so volume control is there. This is the mode where there is a pressure limit is there. And this is the mode where you can have control over the rate also. So basically, this is a combination of three things. This is SIMV plus PSV plus volume guarantee. You adjust the minute ventilation based on the target volume and the rate that you need. If the patient's spontaneous breaths are taking up good tidal volume, the mechanical rate will automatically wean or will decrease. If patient becomes apneic, the set rate and set minute ventilation or tidal volume will be delivered. And that is beauty of this. So if there is no spontaneous breathing, all mandatory breaths will be delivered. When the baby starts beginning, spontaneous breaths are beginning, there is some mandatory and some spontaneous mandatory minute ventilation. And the moment baby is breathing spontaneously nicely, no mandatory ventilation, only spontaneous spontaneous mandatory ventilation will happen. Mandatory will happen. And that is what is you can see here, that this is a much patient. You can see above SIMV plus PSC plus VG, you can see on the top. And this baby was put on MMV. This is what was, you can see the PIP. Hardly 5 or 6 is going. The rate is 40 at the moment. Baby wakes up. Automatic, the weaning on the rate starts. You can see 38, 37, 40, 36. And when baby goes to sleep, again goes to 40. So automatic weaning of the rate is happening with MMB mode. And that is, you can see 33 rate also here. You can see rate over here. So that is what is happening. That's beauty of MMV, where you need not to wean baby off, or be not to wean on the rate. Look at this baby's lungs. These are so badly done. This is typical of BPD. And these are the babies who are on the ventilator for long. You are going to gradually take them off ventilator. And for those small number of babies where they got very bad chronic lung disease, they are on ventilator for very long. This particular mode is very helpful. Another mode, NAVA, will not go into detail because it is not available or not feasible. NAVA is the one which will where the sensor, which is there at the middle of the esophagus, which will pick up the diaphragmatic activity. And based on diaphragm activity, the message is given to the ventilator and a positive pressure which is delivered. That's about that. We'll not go into detail at this stage. What I want to convey is that different ventilator has got different kind of volume ventilations. We need to understand more or less they are all same. They are using the same mode or same concept with the different names. If you are talking about Draeger, it is a volume guarantee, which is their volume ventilation, whatever, which this particular modality is been used by the Draeger for the volume targeted ventilation. Siemens and Servo-I, there is a PRVC. This is the one where the inspiratory pressure is based on inspiratory volume of previous 4 breaths. So your PIP is adjusted based on what is happening in the previous 4 breaths. Volume assured pressure support, which is VIP bird. It is a breath to breath, as I told you. VAPS is the one that adjustment happens within a single breath. It doesn't happen in subsequent breaths like VG or PRVC. VAPS is the one where the volume adjustment, the pressure adjustment will happen within the breath. TTV is SLE. SLE is using TTV, and Bear Cup 750 bias is using volume limit. See, all are different ventilators. All are the same or different name on the mode, but ultimately all are volume targeted ventilation. So having said that, what is evidence? We understand that volume is good, volumetrics is good, volumetrics causes less volume trauma. It also controls the PIP. So many things we have said. And we can see that pressure and volume both are controlled with these hybrid modes. But as I told you earlier, is there evidence for this? Is it beneficial to my babies? And then you look at few systemic reviews and meta-analysis. This has been published 10 years back in archives, where they include 18 RCTs. And these are all kind of babies on volume control modes versus pressure limited ventilation was compared. Babies were less than 2.5 kg, less than 37 weaker. And you can see here that it shows strong trend towards decreasing mortality. First is about the meta-analysis about the mortality. Voluntary ventilation decrease the mortality. Total number 400 babies on volume ventilation and 373 babies on pressure limited ventilation. It is the diamond is on the left side of the bar. That means it is beneficial. It helps in decreasing mortality. It decreases BPD by 39%, big number. So ventilation, volume ventilation is proven to be helpful as far as BPD and survival is concerned. When you talk about other modalities, you can see here, it reduces IVH, PVL, grade 3 and grade 4 IVH, pneumothorax, oxygen days, and hypocarbia. Everything will improve with volume targeted ventilation. What about Cochrane? Primary outcome was, this is from Colin Morley and Peter Davis group. Death before hospital discharge, primary outcome, no difference. So as far as death before discharge, volume ventilation is as good as pressure ventilation. But when it comes to death or BPD, at 36 weeks of corrected gestation age, there is 27% reduction in the BPD. Secondary outcomes, minimal pneumothoracics, RR of 0.52 with confidence interval of within limits. Number needed to test 20. So by treating 20 base volume ventilation, you can save one baby from pneumothoracics. RR of 0.50, 40 to 52 means 48% reduction in pneumothoracics. There is decrease the mean days of mechanical ventilation. Hypocarbia, which is very important for the long-term outcome, neurologic outcome. NNT is 3. By keeping 3 baby on volume ventilation, you can save 1 baby with hypocarbia. which means 51% reduction. And so about the rate of grade of IVH, everything is looking good with this. But then why we are not confident about this? Why in our unit India also or world over, still people are not finding it very useful. We all went in pressure limit. What is the problem? Because ventilator fails to deliver desired channel volume within the set pressure limit. We do not have proper ventilator. Our tubes are uncuffed tubes. And because of uncuffed tube, there is going to be leak. And when leak is more than 30%, the manufacturer themselves tells us that this is of no use. And leak can be, we know that those who are ventilating baby day in, day out, they know that the leak may be 0% to 70%. Flow sensor are not at the right place. Flow sensor normally should be at the proximal end. With this ventilation, flow sensor at distal end. And then which tidal volume is to be targeted? Is that inspirated tidal volume? Is that expirated tidal volume? Which is to be targeted? That is always a problem. You can see here that the circuit of the newborn ventilation is always a compliant circuit. When you buy new ventilator, this compliant, lot of volume is being absorbed or is being lost into this circuit. Second problem is the sensor is at the distal end. Ideally, the sensor has to be at the proximal end. And the problem is at the endotracheal tube leak. So if you can measure this tidal volume at proximal end and calculate leak from the inhale to exhale tidal volume, probably you can do the job. So these are the different portfolios. How can you do that? Better microprocessor required. And you need a Y piece or T piece at the endotracheal tube to measure tidal volume. That will help us. So how can you do that? Get a ventilator meant to deliver desired breath. This is what you can do. Nothing great about it. You can measure and you can circulate. Problem is which tidal volume. So what is volume? Mechanism of volume targeting? You can see here. This is your 6 ml is the tidal which is getting in. Because of the 2 ml leak, only 4 ml is reaching here. So when you target inhaled tidal volume, that means ultimately we will get 4 ml. That means you are not going to, baby is going to get less tidal volume when you are using inhaled inspirated tidal volume. If you are going to target exhalatory tidal volume, what happens? That when baby is exhaling this 4 ml, 1 ml is leaking, so 3 ml is coming out. So when you are targeting exhaled tidal volume, you may end up with giving more to the baby, because here it's coming out 3, actually baby is getting 4. So better would be, rather than getting under ventilation, better to get over ventilation. And that's why it is good to target exhaled tidal volume than inhaled tidal volume. Other thing is leak around the tube. How can you do that? How can you get over it? You need to calculate what is the leak. And how can you do that? You just deduct inspirated tidal volume, exhaled tidal volume from the inspirated tidal volume. So for say 4 is inspiratory, 2 is exhaled, remaining to this 50% the leak. And we have got a ventilator where you can leak compensation takes place. So that 50% leak is being compensated by adjusting the flow. Here is a screen of ventilator where leak compensation is not being switched on. So when it is not being switched on, you can see the same tidal volume is being displayed in the exhaled and in the tidal volume. The moment you switch on leak compensation, you can see here that you are delivering 6.8 tidal volume, but actually baby's exit is 3.5. So if you target this 3.5, probably it is you are ventilating, you will end up better ventilation than not adjusting leak compensation. What about leak adaptation? Again, the same problem. Because of the leak, the triggering mechanism is not working efficiently. Let's say that this is your base flow and this is where the trigger flow is there. When there is a leak, continuous flow is going on. So machine is getting impression that baby means more flow, keep on delivering the breath without terminating it. So triggering is a problem. Termination also becomes a problem. If I adjust the leak by increasing the flow, then probably your termination and triggering criteria can be met with. And that is typical as leak adaptation, that onset of inspiration, there is triggering at this and end of the inspiration, there is a termination. If the leak compensation is on, lead adaptation is on, this criteria will be matched. There are some issues with the spontaneous efforts. Will not go into more detail because of the limited time. What I can say that my baby at times is breathing shallow and at times there are good spontaneous efforts. I want a ventilator which can understand the difference between these two and put an algorithm where it will adjust the pressure accordingly. For example, spontaneous breath should have different algorithm than the mechanical breaths, because mechanical are bigger breaths, they carry different algorithm than the spontaneous breaths. So if you got a ventilator where two different algorithms are there, it will helpful in maintaining adequate transport pressures. Let's discuss about how to put a VG on. The moment baby is put on the VG or put on the ventilator, one need to, in current era, we start with the VG from the word go. We decide SM or assist control. In our unit, we use assist control to begin with. And our backup rate is always 30 to 40, which is 10 more than spontaneous rates. You decide PIP, you decide PEEP, you decide tidal volume depending on the weight of the baby. And depending on, we see, be with the baby, the people, and depending on the how much of the PIP, set PIP is there, I put my Pmax 3 to 5 centimeter above the pressure limit. And then take X-ray, look at the chest AT position, clinically confirm the adequacy of the support. Once the range of PIP is known, I will set the PIP 25 to 30% above the upper range and just leave the baby alone. Believe me, with improvement in the chest compliance, improvement in the lung compliance, automatically PIP starts coming down, because now there's a volume targeting. PIP is also auto weaning. In assist control mode, if the baby is breathing adequately, you will find PIP coming to 12 and 14, depending on the baby's condition. Rate is not to be weaned, it is auto weaning happen. And that's perfect. What you do not need to do when you are weaning, you should not be weaning on tidal volume. Tidal volume is fixed at 3.5 to 4 ml per kg. If you are using SM in small babies, always put the PSV on. And the moment your PIP is reaching 12 to 15 with targeting of 3 to 5 ml per kg of tidal volume, you should take baby off ventilator and put on this. So what are the suggested tidal volumes? You can see here, the smaller the baby, bigger is the tidal volume targeted. Term babies 4 to 0.5. But the preterm babies like RDS, less than 70 gram, you can see the targeted tidal volume is 5.5 to 7 ml, 6 ml per kg. And that is because of there is a dead space in the flow sensor for the small baby. That small dead space is much bigger, it becomes big, and that's why you are targeting a bigger numbers. Whichever mode you are using, one need to be cautious. This is a machine, and machine doesn't have the brain. Use your own. In short, volume ventilation is must in current era. Evidence is robust, but more data is required for small babies, 700 grammers, 600 grammars, because they are small babies, they do not generate enough tidal volume. How can you target that? That's the problem. Small babies, chest compliance is very poor. Their tubes are very small. It's difficult for them to breathe through their straw. And that is why at times they fail in targeting the ventilator itself. How can you target the tidal volume? There is a lot of dead space which they have to come through to get any help from the ventilator. Look for ventilator which can take care of ET leaks. Look for the ventilator which can take for the leak adaptation, leak compensation. These are the one which are important when you are before saying that I failed to deliver set tidal volume. Because of the leak, because of the non-availability of the few leak compensations, at times ventilator will fail to deliver desired tidal volume, and then you get annoyed. Don't do that. Try to select right ventilator which can help your baby. Set tidal volume is different for different baby, different age and different weight. So try to find out right number which can help your baby. Thank you very much. Thanks a lot. Rajesh.
Yeah. Participant, if you have any question, you can put in the chat box. I wanted to ask one or two questions.
Yeah.
Like how much leak we should accept?
It
And
depends.
when should I change my attitude?
It depends on the ventilator. There are ventilators. I'm not marketing anyone, but as far as the Goldsmith is concerned, the Martini Kessler has written that Draeger can compensate up to 80%, which is difficult to believe. Believe me, I use Draeger, but I never see a ventilator compensating for 80%. That's not an easy number to compensate. But at least 50-60% leak, I can see my babies are doing well and without cough tubes. So if you ask number, I don't have the number, but I will go clinically in all the babies. Forget about the numbers, forget the screen. Ultimately, it's a baby, and our clinical examination is more important. Look at the chest expansion. Look at the volume that you how baby is being ventilated or not. Baby is pink and well perfused or not. Mood is stable or not. At times, because the small tube size, as you know, block tubes, all these things, numbers will not tell you. Your clinical examination or clinical acumen will tell you where the things are right or wrong.
True, like if baby is on mild to moderate setting, okay.
Yeah.
If baby is on say high setting, then should we accept the leak? Difficult to ventilate baby and having leak, too much of leak.
As long as chest expansion is adequate, I'm okay with that. Forget about that number. If chest expansion is there, good air sonorization is there, saturation is perfectly all right, I'll not consider the numbers. But with high leak, the chest expansion is not there. That means I need to act differently. That is most important part.
Nowadays in the market, cup TT tubes are available for neonates.
Yeah.
Should I use that?
I will not advise at this stage.
Why?
Because I'm worried about the tracheal trauma. Because that is not a regular practice, in fact. So we are in learning how to use those tubes. So those who are doing regularly using those tubes, they're all right with that. Quick ventilation, you're all right with. If my baby is not getting ventilated because of the leak, very bad lungs, poorly compliant lung, and nothing is working for my baby, either use bigger size tube or use cuff tubes. Cuff tube is not that we are trained with. So bigger size tube, maybe for a day or two, get over the crisis and go back to the previous size. That is what we are doing.
Dr. Ashish, hello.
Hello.
Dr. Ashish, you are right, but some ventilators is like VN's 600 series. They claim that 90% leak can be compensated.
Yeah, that's that.
And we have VNC 600 series. You have shown the VN series also in your presentation.
Yeah.
As we have said that although most of the ventilator they calculate the expiratory tidal volume, even during expiration some amount of leak will be there.
Yeah.
So whatever expiratory tidal volume we are getting, that is not the actually volume that is been delivered to the alveoli. So in VN series, what this is, they give three tidal volume. One is VTE, VTI, and VT. VT means actually what the tidal volume has been delivered to the alveoli. And they have got automatic adjustment in the flow. Their bias flow goes up to even 29 liters per minute flow is there. What I have seen, they compensate because if you are right, suppose there is a leak because of the uncapped tube, we can upsizing the tube and that way we can get rid of the leak. And that might happen even whatever way we fix a endotracheal tube, in certain position of the baby, there may be some amount of leak. And we try to avoid the tube. But if in the VN 800 series, Babylog 8000 plus, they put compensate up to 50%. They say if it is more than 50%, you go for upsizing. But VN 600 series, even in also servo N, they say up to 80 to 90% leak can be compensated.
Yeah, actually, that's what I'm saying. It's already been written there. Hello. That's
yes,
what
yes, you are audible.
that is been mentioned in the Goldsmith also with the ventilator. The Draeger itself can compensate for 80%. So to believe it once it is there in the book, and that too from the Goldsmith, have to accept it.
I am using it is doing. We have got VN 600.
Yeah.
And sometimes what happens, suppose we are ventilating a baby, few babies, they need prolonged ventilation. Every 1 week of ventilation, size of the endotracheal tube increases by 0.5 millimeter, almost 0.5 millimeter. So that way, it is a very good ventilator to use it. But every unit may not be having this kind of ventilator.
Dijan Draeger is Mercedes and everyone cannot afford Mercedes.
Cannot afford. That's true.
That is a problem, isn't it? And to tell the truth, that these high-end ventilators, how much percent of the babies you need to put on high-end ventilators? Very
That is
small.
very few, very few, very few. In fact,
Because
invasive
our
ventilation
target is
is very.
mainly 800 and 1200 gram babies. We're talking about this, about non-invasive ventilation. It is very small
Yes, yes, yes.
who require this kind of sophistication.
Mm-hmm.
So just to targeting the audience that I'm talking to,
No,
I
that's
say
you are
that
right.
yes, Draeger 80% very good. SLE
Mm-hmm.
also they claim that 60-70% they can compensate. Principle is that when you talk about volume ventilation, at least leak compensation and leak adaptation has to be there. One need to go into the detail, and then if
Yes.
these are there, then only go for volume ventilation. Otherwise, there should be
Mm-hmm.
already the pressure ventilation. That is what my message would be.
No, no, yes, yes, thank you.
Yep.
And what volume you target? Lower or
We
higher?
try to 4 to 5 ml. Rajesh, we start with the 4 to 5 ml volume.
Four
If
and five, there's a lot of difference. 4 and 5.
okay,
4.5.
for the unit again, that depends on the for the consultant in my unit. But if I am there, 4 ml per kg. That's the thing. Because why I'm saying so, because in the beginning we have seen that 4 ml per kg will not allow me to get to that PIP to expand the lungs.
Yes, yes.
So that's why I give them liberty to increase the turbine for a little bit till the surface delivered. The moment surface delivered, automatically you'll see that PIP starts coming down.
Is it same for 800 grams baby and 4 kg baby or some?
800 gram baby, you try to keep in 5 to 6 ml per kg. For the
Yeah.
smaller the baby, I'll be taking on 4.5, 5.5, 6 ml per kg. But and a BPD babies, you go to 6 to 7 ml per kg. So chronicity will increase the tidal volume because the lungs are very bad and you want to target the good tidal volume. The bigger ones, you may already with 3 or 4 ml per kg. But again, it is not the number. It is again, you are looking at the baby, you look at the loops, you look at other numbers also. Not only one tidal volume number. That is what I will say.
For the beginner, what I do, what I advise, and before going to the regular volume ventilation, but at least when you are giving surfactant, you put that volume target or volume guarantee on, because that is we have rapidly changing pathophysiology. So automatically pressure will come down and ventilator will take care. If you don't do that, maybe pneumothorax.
Yep.
And I say you do it for 2-3 months, just after giving surfactant. Once you get used to it, then we go for a routine volume guarantee or volume target ventilation.
True.
And also, like again in the beginning of presentation, I told you, never rely on the your distal flow
This is
sensor.
the processor, yes.
Flow sensor, which is there inside the ventilator. Always on proximal. So that is the thing, because many of the times now the company will say like sir, flow sensor is there inside. So don't believe on that. That is not used in neonates. At least even people say till infancy, till 10 kg it is not reliable. After 10 kg you can rely on that. But before, surely, definitely not in neonatal period.
Yep.
So volume ventilation, but problem is where the high volume there, like there are many types, like in government hospital or busy hospital where we have residents changing over every almost 3 times a day, and consultants also sometimes changing. And the experience of the consultants will be different, and the residents will be the first year or maybe third year SR. What do you advise? Volume ventilation or pressure ventilation? Pressure control.
See, problem with the one is you need a good sensing, flow sensor. And that is always a problem with busy nurseries, because flow sensor is, as you know, is very sensitive thing with the secretions, with the cleaning, the way that it's been handled. Without proper flow sensor, number will not work. In that case, I'm happy with the basic ventilation rather than going for sophistication. Stick to your basic principles. As I told you, we do not have many babies who need this sophistication. In the units like ours, all of three, where you got proper monitoring all the time, in that case, this ventilator will do good for our babies. But the places where things are not available, not possible to monitor, better to stick to the basic thing.
That is the thing I wanted to highlight.
Mm.
Please stick to the basic, whatever you are doing with experience, but have a look on the delivered tidal volume.
Yep.
You may not target or guarantee, but you should keep on monitoring how much volume is being delivered so that you can change your pressures. So, Bijan, any
Rajesh, hello.
yes.
Yep.
Rajesh, I think you are right. What I want to highlight, you have already told, people should know whether their flow sensor is working or not. They should understand. Many times we will find ventilator is going on, running, but the flow sensor is not working. That's why you always say that if you see the graphics, if you see only the pressure, with your proximal sensor pressure scalar, there is no flow or volume. That means your flow sensor is not working. Many times people do not know actually it is not working. So that if the flow sensor is not working, what we have discussed, all this triggered ventilation, even the basic ventilation, this will be meaningless. That's why I think this resident, the new consultant, whatever, they should understand whether their flow sensor is working or not. And I think all of you will agree with me that most of the time the flow sensor sometimes gets out of order within 1 or days, 2 days, or as we have seen the condensation, leak, etc., can also influence the performance of the flow sensor. I think the ventilation basics is important, as you have rightly said, and also the flow sensor. Without flow sensor, all these modes that becomes a meaningless. So that's why all the units they should learn whether their flow sensor, whatever is the flow sensor, whether it is working or not. And that is one way is that you can see the graphics and see whether the sometimes if there is a digital flow sensor in some machine, there is a provision for digital flow sensor as well as proximal flow sensor. If the proximal flow sensor does not work, it automatically goes digital flow sensor takes over. That also they should understand.
Yeah,
Sometimes they may find that the pressure, flow, volume, everything is there. That means the proximal flow sensor is working. That is not the case. Again, we will be on the wrong foot.
Yes,
I think these
the same point I wanted to highlight, but you have highlighted because there are machines where both flow sensor, distal as well as
Hmm.
proximal. Proximal goes off, then ventilator will switch on to distal. I will not know which flow sensor is working. So you have to go into the see, and there will be in ventilator settings which flow sensor is working, proximal or distal. So
Rajesh, this servo and they say that proximal, they give the message in the screen.
mhm.
There's a proximal flow sensor disconnected or something like that.
Yeah,
So
yeah.
that we understand.
Yeah, most of the ventilators will give you the message, but
The message.
sister will put it off before you come.
Very true.
That is the problem.
That
Okay.
is the
So thanks, Ashish.
Thank you.
It was a very
thank
good
you, Ashish,
lecture.
for the excellent presentation.
Hope
Thanks.
we will have more learning during the workstations at the Bhubaneswar.
There are many more modes to discuss, but then ultimately it will.
There are so many modes.
Yeah,
There are so many modes.
there are pressure assist, volume support. Then there is proportional assist volume support. Then
Proportional
there
access
is
ventilation.
the auto release volume support. There are so many things are there.
And
I've got the flu presentation, but then it was too much of that. Don't
in,
want to bore that.
in GE nowadays we have bi-level VG. I don't know what is the but they say you have a fixed volume and also a minimum pressure also they guarantee. If that much pressure is not achieving and volume is being more than the what we have said, it will give that much pressure. So you have to set the minimum pressure, you have to set the maximum pressure, and in between the volume. All three, it will control. So there are so many things. So it keeps on, but most important that you have to know your machine.
Absolutely.
So you can know your machine before you use it. Like don't drive a car before you know how to drive a car. So you will do the
Bijan, how to take care of the flow sensor, particularly with VN?
VN, see, my one thing is that I have got the flow sensor of VN as I have got two machines like Sarvane also. In the sometimes what happens, this is a practical problem what we have experienced.
Yeah.
In servo N, the circuit that the ohm is 17.5 ohm.
Oh,
17.5 in VNC is 600 and Babylog 8000 plus, but in servo it is 20 ohm. Sometimes what happen, if you keep that humidifier, that 20 ohm circuit, immediately your flow sensor will go off.
oh my
This
God.
happened in our case many a times. Even in 1 hour, we changed 3 flow sensors. After that, we came to know actually in some unit there are so many ventilators. So when you are using Babylog 8000 plus or Servo N, then you just see what is the circuit ohm, that it should be not more than 17.5. In Mackay, it is 20. If it is more than 17.5, immediately that tungsten pillar, that wire will go off. That
Yeah,
is one.
the problem is about the secretions and all that, you know, that
And secretion, what we do, I am using reusable circuit, and reusable circuit, after similar uses, there will be some